Okay, so we are off to the races, right? Many of you are going through final exams. Some of you are starting a new semester. Many of you are planning to take your NCLEX. Some of you have got to take a HESI. This lecture is management of care, and it's a very broad topic. For the LPN, this correlates with coordinated care. Okay, so this is for both nurses, RN and LPN, and this is for both, I should say, any test, final exams, HESI, ATI, any other exit exam you need, but absolutely the NGN NCLEX. Now, I want to point out that this is about 20% of your test. Management of care is 20% of your test. However, you know me, I have pink packets in what we call the other issues on the test, right? So if you've been following me even for 15 seconds, you probably have figured out it's the pink packets that make up the test. So remember what the pink packets are, because I have a little special for you. Pink packets include management of care, which right now, the only way to get a management of care is through the pink packet bundle. And that pink packet bundle is $99. Yeah, so listen up, I got you. I do have a deal. So we have our management of care, that's one. We have the famous and the necessary. You can't do anything at all before you buy it. Oh my God, packet. I used to give it away for free. That's two. It's no longer free. It's $25. We have the procedures and reduction of risk, rather. Why is this one the most important packet, possibly to about 90% of you? Because it's the #1 area of failure on the NGN NCLEX. It used to be basic care and comfort on the old test. Now the new test, basic care and comfort and reduction of risk. So there's that. And that's now #3. Then many of you failed, and I just did a video last week, so it's the latest information. If you need this and you failed in this category, this is the pink packet for you. Infectious disease transmission-based precautions. So infectious diseases and transmission-based precautions. Not only does it give you the contact, the droplet, the airborne, the standard, the protective, it also has a whole list of what infectious diseases you need to know. I want to show you that real quick. This basically is a whole list of the various infectious diseases. We tell our students to make a flashcard out of every one of those and put the precautions on the back. So this is your 4th packet. That was infectious disease. That was your 4th packet. Are you counting? Because I'm going somewhere. Then you know that I recently upgraded medication categories. And so this is 2024. That's 5. Are you staying, with me here? This is 5. Then we have our psych meds, because so many of you failed in psych. So psychological adaptation on your candidate report was you. That is now 6. And then we also have, as part of a lovely little deal, we have this handy dandy little psych packet, because it's the first subject that we teach you need to master in. So we want you to know that you are supposed to be making sure that you start with psych as your mastery topic. Okay, so I don't know if you're counting. Let's see what we got so far. we have, here we go. We've got our Management of Care 1, Oh My God packet 2, Procedures Reduction of Risk 3, Infectious Disease and Transmission-Based Precautions 4, Psych Meds 5, Medication Categories newly updated 6, and Psych. So here we go. Right now, to get a combination of that, the way I just did it for you is about $120. Just the pink packets are $99. Until Christmas, you can get, well, all right, fine. Until New Year's Day, you can get 7 for $77. Did you peep that out? Yeah, I said 7 for $77. Which 7 again? 1, 2, 3, 4, 5, 6, 7. 7 for $77. I know, right? Now, what do you have to do it? Here you go. What do you have to do to get it, rather? Here you go. You've got to text me 216-410-0936. You cannot get this through the link through our NCLEX Prep Shop. You can't buy that through the link because it's a special made deal. You get them emailed to you as PDFs. Now, don't call me and tell me you can't open it once you get it, because if you can't open it, it's your computer system fault and you want to figure it out. Get somebody with a clue about why you personally can't open what thousands of students can open. That's important, okay? Now we can get started. So, management of care. Thank you to the student who asked if there was a management of care video, which is the trigger for this video. I thought that was really kind of cool. She asked yesterday, is there a management of care video? And then I said today, get your ass out of bed and make a management of care video. Now, management of care is huge. So your understanding of management of care, which is again about 20% of your test, is that you've got to remember it talks about prioritization, it includes delegation, ethical legal, workplace conflict, SBAR handoff, advanced directives and DNRs and hospice and palliative care, roommates, and it's a lot, right? It includes a lot. Evidence-based practice, emotional intelligence. It's a lot, and that's why the packet is so nice. So today, what I'm doing is I'm doing part 1 of management of care, and I'm looking at just the legal portion, okay? So we're just covering the legal issues, because as you can see behind me, it's a lot. I already did prioritization, so you can feel good about the fact that we took care of that already and it's already in the videos. This playlist will be a new playlist. The playlist will be called Management of Care, and I will follow it with another video on ethical dilemmas or ethical concerns in nursing, and then I'll follow it with another video that talks about delegation in nursing. So let's go. Let's get started with management of care, the legal issues, okay? So pretty much everything on my board has a law attached to it or some legal implication where you're kind of in trouble if you don't do it, or you can, if you don't practice in the scope, you can get into a little bit of, difficulties as a nurse, okay? So let's get started. Here we go. I think if I stand over here, it's pretty good. I tried to do this in alphabetical order because your management of care packet is in alphabetical order. So I thought it would follow and flow, but let it be known that your Oh My God packet also has an ethical legal section. So right now, if you don't have the management of care packet, you can find the ethical legal section in your Oh My God packet, and all you have to do is turn to page 14. And so you may want to highlight some things as I cover them on page 14 with the ethical legal issues, okay? All right, ethical legal, there you go, Oh My God packet. All right, so that's why I said the Oh My God packet is priceless. All right, so let's get started. Don't forget your 77 for 7. You have to say that to get what you need, because I have a lot of specials going on, and I don't know what you need if you don't say 77 for 7. And I take Cash App. I do not take Zelle yet. I'm looking into it because a lot of you have Zelle, but I do take Cash App and I do take PayPal. So hopefully that helps. All right, here we go. Abandonment. Abandonment is breaking the law. You absolutely, as a nurse, must not leave the facility until you've given handoff report to the next nurse. Now, this protects both nurses, because what I have noticed, especially in this current environment where when you get report, maybe a significant number of nurses are what we call agency or travelers, and maybe they just have a lack of knowledge about how things are done in the hospital that you work in. Well, I've gotten to the point that some things that they're trying to tell me in report may represent an issue of care for the patient, whether it's no blood work was done that was ordered 12 hours ago or 10 hours ago or 8 hours ago, whether it's the central line dressing is almost off, if not half off, or, you know, it's coming off and soiled or soiled. There's just been a few times where this person is trying to give me handoff report, and I state very firmly, I'm not going to take report until you can get that blood work that was ordered for the patient, because I don't see anywhere in here that you even tried. And also if you can make sure that that dressing on that central line is changed before you leave. In other words, instead of being dumped on this nurse coming on, which would have been me, I don't want to be dumped on. So I don't want report, because once I take report, I have the patient. So the nurse knows by law, you have to give report to another nurse before you can leave the facility talking about I'm out. No, that doesn't work so well. Okay, so I want you to understand that abandonment is a very real law that you break if you decide you want to just bounce and you didn't give anybody report. That's illegal. Okay, now the other thing is the implications for home care. If you are a home care nurse, this gets you into a little bit of difficulty if you need to take time off, or you need a day off, or especially if you're an independent provider, right? So if you have a PIN number, you are the boss. You have to make sure that you have coverage for whatever day off you needed. There was literally a student in my class who was coming to class, and unbeknownst to me, this LPN to RN, which means that he's taking an RN test, but he's currently an LPN bridge student. This LPN to RN had skipped out on taking care of a child on a ventilator, did not provide coverage for this family for this child on a ventilator, and this was his patient, not through an agency. He was an independent provider. Yeah, that was reported to the Board of Nursing. So when he called me and told me, what do? I got reported for this and that. I said, what the hell? What was going on that you just up and didn't go to the daggone case? Like, what was that? Do you know what this fool said? I had class. Oh my God. Tell me you didn't do that. Okay, so think it through before you take on these cases as an independent provider, because here's the deal. You must provide coverage if you need to miss a day. And also, if you decide that you're no longer going to want to take care of that patient, which I've also seen as well, you're going to need to provide a 30-day certified mail notification that in 30 days you will no longer be caring for this patient. I'll try that again. If you decide that you can't, won't, don't, are not going to care for the patient in home care, you must provide certified mail notification that you are no longer going to be providing services for that home care patient. Just dipping out and saying, I can't do this no more, that's not good enough. Okay, so that's abandonment. Advanced directives. I think we know what this is, but I'm still getting confused, students. So advanced directives is the patient's wishes with regards to their personal medical care that are written in the event they can't tell you or communicate what they want. So if I'm intubated, my advanced directives speak for me. If I'm in a coma, my advanced directives speak for me. They are written. They are provided to the hospital. By law, we must have them if you have one and you want us to go by it, right? And so advanced directives is a broad umbrella term because it includes several components. Under the advanced directives umbrella is something called a living will. No, it's not who gets your bicycle when you die. No, not that kind of will. What it is do you want extensive, expansive measures to save your life? Do you want to be a do not resuscitate, do not intubate? Do you want any of that? Do you want to be a full code, whereas that we go all out and try to save your life? What is your living will? What do you want in terms of that? Do you want to be an organ donor? So this would be organ procurement, right? Do you want to be an organ donor? Is that part of your wishes, of your living will? Don't forget that the DNR or DNI or whatever that is, even though the wishes are in the living will, the doctor comes around and makes an order in the chart, DNR, full code, whatever. Now, the thing is, advanced directives only need 2 witnesses. The 2 witnesses can't be the medical proxy, the healthcare proxy, or family, or anything involved in the actual advanced directives. It can be healthcare professionals. I've been a witness when a patient all of a sudden wanted to change their advanced directives. I've actually been a witness, and that's what we want. We want someone objective to be a witness. So you just need 2 witnesses or a notary. If it's not notarized, it still is very, very, very accurate, very much legal. It just requires that 2 witnesses actually sign off on it. This advanced directives must include your, should include your durable medical power of attorney, which is also called healthcare proxy. What I mean by that is the durable medical power of attorney or healthcare proxy is who you want to speak for you in the event that you can't talk and they need to make right now decisions regarding your medical health care. Now, be careful. They cannot make medical decisions about selling your house. They can't make decisions about taking your car and selling it. They can't make anything but medical decisions. You can change who you want anytime you want. I've been a witness to that at the hospital level, and I wanted to bring that up because there were some family members. Actually, I was getting a call from twice removed mother, brother, sister's cat, twice removed, calling me about the patient every shift, and I had the patient a few days, and I would go in the room and I'd tell this person, so-and-so called from Columbus. I'm in Cleveland. And they were like, yeah, I know. So finally I was like, when I had a minute, I was like, okay, what is going on here now? I'm looking at your daughter sitting at your bedside nonstop, but you got this so-and-so twice removed sisters, brothers, mother's cat calling me from Columbus, asking about you, talking about they're your durable power of attorney. You do know that you and only you have the right to choose who your power of attorney is. He said, and I quote, this is the beloved patient. He said, and I quote, "Oh, really? Oh, because I thought it had to be an attorney." I said, no, it could be Joe Blow, neighbor's daughter, kid, whatever. It could be anybody you want it to be. And no, it doesn't have to be an attorney. Well, this attorney had told him that it had to be an attorney. And since he was an attorney, he could be the power of attorney. So be careful. It could be anybody you want. It doesn't have to be blood kin. Maybe you and your neighbor are closer than you and your sister, who's a hot ass mess. I don't know, but you got to remember that, okay? All right, now I put this in here because I thought while we're talking about DNI and DNRs and all that kind of stuff, do not intubate, do not resuscitate, full codes, whatever. While we're talking about that, I thought I would mention the difference between hospice and palliative care. Remember that hospice is an insurance certification that is based on a 6-month life expectancy. The care is multidisciplinary and can be given anywhere: hospital, home, nursing facility, wherever the patient is, their hospice goes with them. And the care is focused on a dignified, pain-free, or at least reduced pain, comfortable, I guess, transition to death. And it's supportive of the family. And frankly, having used the services of hospice, my favorite is Western Reserve. The services of hospice were incredibly worthy and unforgettable, and I will always speak positively about hospice. They were amazing in my papa's life, okay? So I'm telling you, down to the hour, they told us when he was going to pass. And that really helped because it was during finals week and my daughter was at Ohio State and I had to go drive down 2 hours to go get her. So, and she's the only granddaughter and Papa's favorite person other than his wife. And I mean, all this shit. And I had to go down and get her so that she could be at his bedside. But yet I didn't want to have her sitting there for weeks or days even. I just needed to know like closer to when they thought this would happen. And they are experts at the signs of death, upcoming death, right? So I can't say enough good about them. I think nurses have an awkward stance when it comes to hospice. They don't know how to talk to patients about it. And the word hospice evokes so many emotions that I've gotten to the place where I try to encourage you to bring it up like this. I saw that they kind of don't know if your father is going to, live past a few months, and they think this is really bad. And he's kind of gone through chemo and radiation and doesn't want to do it anymore. And I don't know about you, but there's this specialized type of care. I don't know if you know this, but there's a specialized type of care that focuses on the patient in their last few months of life. And that's all they do. Like that's their specialty. And I'm impressed with them because I used them for my papa and they were so caring. They still kept in touch with my mama like a year later after he died. They remembered their wedding anniversary. They sent flowers, but while my papa was living, they made sure he didn't suffer. They also gave us like all of these supplies and equipment to put in the home. And that was part of going with this type of specialized care at the end of life. And it was like a bed, some different different equipment and products that he needed to transition. And, you know, we didn't know when that could be. We didn't know whether it was going to be tomorrow or next month or 6 months later. And sometimes, you know, since we're not God, we could be wrong on that, but it's okay because there's nothing wrong with choosing to go with this specialized type of service. And then finding out you didn't need it. Nothing's wrong with that. You just got extra love. So I don't know if you've thought about it. I don't even know if you've heard about it. I know that certain people may have heard the word hospice and get a little worried about that word, like almost sick to their stomach because they're realizing hospice means my dad's going to die or whatever. But you and I both know all of us are going to die. And I just feel like maybe your father would benefit from this specialized kind of service. So, you know, talk to the doctor about it. See what you think. It worked in our situation. I hope you find it beneficial in yours. And boom, you're done. Okay. Now, so hospice, again, is an insurance term with regards to 6 months certification that the life expectancy is no more than 6 months. But something that does exactly the same thing, but doesn't have a life expectancy attached to it. It just has the fact that whatever the patient is going through can't be cured. That's called palliative care. And palliative care is for the patients who have situations like cirrhosis or COPD or cancer, serious, they're very sick, but they need more like comfort care. An example of comfort care for the cirrhosis patient is a paracentesis to make that patient more comfortable and better able to breathe. So that's the difference between hospice and palliative care. Now, the next term is AMA, against medical advice. So your patient is triaged. They're in the emergency room. They've been triaged. They came in with abdominal pain, and there they sit and sit and sit and sit. And then they come up to the front counter and they say, listen, I can't sit here this long. I'm getting the fuck up out of here. I ain't got this kind of time. Y'all on some trash. I see y'all back there eating donuts, and I've been sitting here in pain, and yada, 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 yada. That's kind of realistic, right? Sadly, it is realistic. So what is your role, nurse? Well, if you're an LPN, your role is to go grab the RN. If you're an RN, your role is to say to the patient, and only when it's honestly, truly applicable, you say to the patient, you know what? I get it. You have been waiting a while. I know you want to leave, and that is your right. I'm not going to keep you from leaving, but I do want to explain that, number one, you came in with abdominal pain, and leaving, and we don't know what that abdominal pain is from, could possibly end up resulting in disability or even death if it's something very serious. Now, what I'm going to do, because I know you got to leave. I know, I get it. But what I'm going to do right now is I am going to notify the provider real quick and tell them how you feel about this, that you're leaving, and to see if there's any different plan that he can come up with. But right now, I'm just letting you know I get it, but I also want you to understand that if you leave, and let's say this abdominal pain is pancreatitis or peritonitis, which are all very serious abdominal conditions, tummy, that affect your tummy, your stomach hurting. In those situations and several others, you could be risking your life. And I'm so sorry that it's been so long since you came and you still have not received care. But that's what I wanted to make sure you knew. Now, if he says, if you gave a damn that much, you would have seen me by now, or if you thought it was all that, y'all should have pulled me back, or whatever the situation is, you know, just stay humble and kind and loving and let them go ahead on and do what they got to do. But you better go find that doctor, notify them, document that you notified the doctor, document that you notified the patient of the risk involved in leaving AMA, including death. And I did say that word. I said death. Okay, because that's real. Okay, so that's how we handle AMA. At no time do you forbid a patient to leave. Never. Okay, you physically need to stay the hell out the way. You can't stop a person from leaving if they want to leave. Okay, so that's the deal. Assault and battery. Uh-oh. Many times we say these terms together, but we need to separate them for the purpose of HESI and NCLEX. So when we look at assault, which is different from battery, the word assault actually means threaten. So you know what I'm going to do, right? You know that I'm going to go over the different ways that nurses have taken it upon themselves to threaten the patient. If you don't quit calling that, if you don't quit ringing that call bell, I'm going to take it from you. Oh, yeah. And I've even seen it taken, which you already know I reported that. If you keep calling me when it is time for your pain medicine, I'm going to be late. Yeah, I mean, I've seen all of this. If you don't stop screaming, I'm going to close the door and nobody's going to hear you anyway. Oh, God, I've heard it all. Okay, so you want to know that those are illegal acts and those are reportable. And that is crazy for any nurse to do it. And I've seen it. The other part is battery. Battery, I want you to think baseball bat. So battery, baseball bat, you actually physically made contact with the patient in a way that they didn't want to. What does that mean? Oh, I got lots of examples of this. I'll try to give you just a couple. I had a young lady call me up crying. She was a nursing assistant. She had just been fired. The nursing assistant called me up crying. She was also a student in my class trying to take her NCLEX. She came immediately to this office, this classroom, and she said, Miss Shelly, I just need to know, am I going to be arrested? What's going to happen? I don't know what's going on. Like, they reporting everybody. I said, oh my God, baby, what happened? She said, well, it was this man that the doctor ordered a TB test on. And she was talking about this man in a long-term care facility. And he was like 80 something and he had a little dementia. And so he was ordered a TB test and he told the nurse no. And she was like, well, the doctor ordered it, so you got to have it. He was like, I don't want no needles. No, I said no. And she told me and 3 other aides to hold him down while she gave it to him. What the fuck? Are you serious? Okay, so what you guys did to that person was battery. In other words, restraining a person for no reason for a TB test is illegal. That RN is probably in major trouble. You've been fired, but thank God that you're not a nurse right now, because you'd have a report going right to the Board of Nursing and jeopardizing your license. This is crazy on steroids. So let me give you other things that's crazy on steroids. The patient said she didn't want a Foley. You put one in her anyway. The patient said they didn't want an IV. You put one in her anyway. The patient said absolutely no to the NG. You put it in her anyway. Nah, man, that's crazy as hell. You cannot do this to patients who are 18 and competent. Now, we're going to talk about who is incompetent, but if they're 18 and competent, they have the right to say no to those procedures that I just went over, and that is protected by the federal statute called Patient Self-Determination Act. They have the right to make decisions for themselves. Unless they've been proven to be incompetent, you are completely wrong and breaking the law. So when they don't want a Foley, they don't want an IV, they don't want their blood drawn, they don't want an NG, they don't want any of this stuff, the answer is deuces. I ain't finna force nobody to do nothing. Okay, cool. Document your ass off. Now listen to me. You can't be the stupid nurse and be like, oh, he ain't want no IV, good. No, retard. You must make a good effort, a good faith effort of explaining and loving your patient into understanding why they need this and what could happen if we don't get it. If they still say no, no means no, not just with rape. No means no with anything you're doing that physically makes you touch another patient in a way they don't want to be touched. Okay? case management, I thought I would cover because you hear and see those terms and probably are like, what the fuck is that? So case management is usually an RN who's in charge of the care. And remember, a lot of it has to do with discharge planning, but discharge planning starts on admission. So you've got to remember that the case manager is involved from admission all the way through. And what they're doing is trying to coordinate where the patient's going to go after they're discharged from the hospital. Do they need long-term care facility? Do they need rehabilitation? Do they need an LTAC, which is long-term acute care? Do they need to just go home and have home care? Do they need to just go home and get a ride home, but they don't need anything else? What do they need? So their medical and nursing needs are going to be investigated and analyzed by the case manager in order to prevent readmission in the next 30 days and to facilitate healing. That's what a case manager does. And it starts from admission. Okay, so I hope that helps. Chain of command. When we look at chain of command, this is what did you do to escalate to a higher power, someone that could do something about the situation. What did you do? And you may need to move up the chain of command for nursing, or you may need to move up the chain of command for medicine, which means your providers. I have had to move up the chain of command twice in my career. I'll give you both examples. The first example was the patient was in labor and the fetal heart rate was basically decelling, and the decels were late decels. You know what that means. That's uteroplacental insufficiency. And the decels were continuous, and the decels were pretty bad. And so you've got every reason in the world why this patient needs a C-section. And with love and care and explaining and compassion, no matter who did it, even I, the charge nurse at that time, walked in the room with my technique, which is pretty good. I have great success with patient communication, and I'm even explaining to her that she needs a C-section. It didn't matter. It didn't matter who explained what, and this is in the middle of the night, of course. It didn't matter who explained what. Basically, she said no. So the doctors, the residents on the unit, you know, Grey's Anatomy residents, the residents on the unit said, we don't care, we're cutting her. At which point I had to say, no, you're not. This is what you're not gonna do, because if you cut this woman against her will, that's called battery. Yeah, that's illegal. So that's what you're not gonna do. And so the nurses that the nurse that was responsible for the patient, the residents that were responsible for the patient, they were all on the same page to just cut this woman anyway. And I said, oh God, no. And so I had to go up the chain of command, right? Because I am a nurse, I involve nursing, but I truly had to go up the medical chain of command. It didn't stop, because I had to go all the way up. It didn't stop till I got the Medical Board of Bioethics, legal and bioethics. That was the top of the command. And they did come in and stop any notion of cutting a patient that said no. So they brought their little size 10 high heel 3-inch heel, high heel wearing self up in there at 3 in the morning, stomping, you know, like, hey, no one is getting cut here against their will. Absolutely not. That's illegal. That was one time. The other time that I had to go up the chain of command, and I did not have to go to the top, but I did have to go all the way up the chain of command, was I had a doctor who was trying to do an oxytocin challenge test on a patient that was 26 weeks and had failed their BPP, which, as you know, because it's in your maternity packet, the BPP is a biophysical profile ultrasound with the monitor test that goes with it, an NST. So BPP, NST goes together, and the patient did not score well. So you may remember there's 10 out of 10 points on this test. This patient scored 6, and she wanted to do the next test, which would have been appropriate if the patient was full term, but she wasn't. She was 26 weeks. And I said, and she was a second-year resident. And I said, oh, no, we're not doing that. She's 26 weeks. And if she takes off from this oxytocin and kicks into labor, we've got a very premature baby on our hands. And I don't think that's a good idea. Well, she kind of told me she's the doctor, I'm the nurse, and she's gonna go ahead with it. And I kind of explained in my Dr. Shelley kind of way, like, oh, no, the hell you ain't. Nah, we ain't doing that. Here's what's gonna happen. You are not going to start Pitocin on this patient because you need nursing to start it. And I'm not gonna authorize the nurse to do something unsafe. So she kept saying she was just gonna find another person to do it. And God bless her. But I did have to go above her head. The person above her was a third year and said, whatever she said sounds reasonable to me. I'm like, no, it ain't. Had to go above his head, and that person was the chief OB, sort of like Dr. Bailey on Grey's Anatomy. And she was like, I mean, whatever, I don't care. And then I had to go above her head to the attending, and this was day shift, thank God, because the attending was upstairs. I had to go above their head to the attending OBGYN, and that doctor was like, she want to do what? Oh, hell no. She came stomping down the stairs from the 7th floor at the time. I'm on Mac 2, I'm on the 2nd floor, Mac 2, and she told her, she said, what's up with you? You not listening to nurses now? I mean, Shelly been around a while. You better listen to this one. If she told you no, no means no. You're gonna cause this patient possibly to deliver at 26 weeks. And she was fine before you started Pitocin. So absolutely not. We're not doing that. Now, it was a little rocky because, as you know, sometimes people take things personal, and it was rocky. Don't get it twisted. It kind of sucked. But let me tell you something. That person got better every year. I complimented her at the end of her 3rd year and said, I wouldn't be surprised if you made chief. And guess what? She did, because chief is not everybody. You have to be chosen to be the chief doctor, like Dr. Bailey was chosen for her excellence. So she got chosen to be chief, her chief year. And then once she had been a private practitioner in OBGYN, I decided to go to her because she really was really good. And the best compliment any nurse can give a provider is to become their patient. She was shocked. I gave her a hug. It ended up that our kids took ballet together, and now, right now, 2023 going into 2024, she's the CEO of 2 hospitals. So she got really good. It's never personal. It's patient advocacy. Okay, so hopefully that lets you know what to do. Now, I'm just gonna pretend like a nurse had to go up the chain of command, okay? So here we go. Nursing assistant, LPN, RN, I hope you're taking notes. I'll try it again. Nursing assistant, LPN, RN, charge nurse, assistant nurse manager or nursing supervisor, that's what the test will probably call it, nursing supervisor, nurse manager of the whole unit, building supervisor. So this one is in charge of all the buildings. You see them a lot on the weekends. They're in charge of all the buildings, right? And then you have your vice president of nursing, and then you have your CNO, right? Now on the doctor's side, intern, intern or nurse practitioner, nurse midwife, resident, right? So those are like at the bottom level, and then above that is the chief, which is still a resident. They're all doctors, they're all MDs, but the chief is in charge of all the residents. And then above that comes the attending. Usually your nurse practitioners and midwives follow under an attending, but they're not under them, they work with them. So in our state of Ohio, we are lateral. And I forgot to tell you, management of care sometimes is very state-based. So we are lateral with our attendings that are covering us. And then after the attending, if there is a problem, you will need the director of the department. So in my case, it was the perinatal chair of OBGYN. So, you know, that you would need. And then if that doesn't work, you need the medical director or even the CEO of the hospital. So again, the Board of Legal and Ethics Dilemmas, or Board of Ethics, Legal, and whatever, that is usually above everybody also in many institutions. So I hope that chain of command helps. Now we have competency. When it comes to competency, this patient is competent until the courts prove that they're not. So you can't assume because they have Alzheimer's. You can't assume because they're bipolar. You can't assume because they have schizophrenia that they're not competent. If they aren't, it had to be determined by a court. So competency, as long as they're 18 years old, they can give consent. Now, competency can be questioned, and there can be an involuntary commitment in times where you believe others are at risk or the patient is at risk of hurting or killing themselves. This is what's known collectively as a pink slip. Oh, we're gonna pink slip you, you know, that kind of thing. That would be a threat. You don't want to do that because that's assault. But, you know, I've heard people say pink slip, right? So pink slip or involuntary commitment is only good for 72 hours until it can get to court. And those 72 hours are basically only those hours that are business days. So if you're in there on a Thursday, you're gonna be there till Monday, because we don't count Saturday and Sunday because the courts aren't open on Saturday and Sunday. When it comes to involuntary commitment, you gotta remember only the 3 Ps can actually do it. So who is that? Police, physician, and the public county administrator. I hope that makes sense, okay? So I just did the first column of management of care, legal. I'm about to do the second column because we want to break this up because you guys have a short attention span. And so I'm hoping that you go ahead and go catch something for lunch and join me later.